This is our nasal cannula. So this is a delivery device for low concentrations of oxygen. Anywhere from like 24% to 40%. 1 liter per minute flow on your regulator here on your tank, or up to 6 liters. Depending on where you work though, they allow for high flow to go through this. High flow nasal prongs for like cardiac arrest situations, for passive oxygenation. Especially maybe in the beginning of a cardiac arrest. So in the beginning of a cardiac arrest, what are your priorities? CPR plus what? Hopefully. It'd be good if it works. For 2 rhythms. There's 2 rhythms that defibrillator shocks. VF or VT. So if they're asystole or flatline, not gonna work. If it's an organized rhythm on the monitor without a pulse, that's called PEA, pulseless electrical activity. So that will not work. The only thing that you can do is do CPR every 2 minutes and then reanalyze with that monitor and hope that that rhythm changes. An advanced care paramedic can use drugs like epinephrine, which will chemically create maybe a VF. The heart may respond to that, create a VF or a VT. And then we can shock that. But the priority for you is not oxygenation and cardiac arrest early. Right to CPR, getting that monitor, hooking up to your patient, analyzing that rhythm, back to CPR. Then your partner can do something like nasal prongs, or in Nova Scotia, I think the dispatch information goes right to a non-rebreather mask, which was here a second ago, but whatever. We'll do that one in a second. Nasal prongs, some people are on this for the rest of their known life. So older person at home or in a hospital setting, nursing home, will have these on because they require low doses of oxygen over time. So there might be a device off to the corner of the room that mixes oxygen with some of the room air and delivers it through the nose. This will still dry out their nose over time. The most comfortable device, but over time can also create problems with patients. And it simply fits. So you guys are all sitting down low, but I like to approach my patient from the front. I initially hold it like this so that there's a bit of a bottom piece right here. There's a tiny bit of curve to them. Some devices are even more pronounced with a curve, with these 2 little openings, which delivers the oxygen. And I just place it directly into the patient's nose like this. And I come around their ears to get it in position. Very difficult with mannequin ears because the ear doesn't really exist as much behind the ear. And then I bring this little adjusting piece in up to their chin, just a little tight, which will hold it in place around their ears. And then we hook it up to the oxygen tank, and we choose with our regulator between 1 or 6 liters per minute. And Dan will tell you the exact concentration of active oxygen in his lab theory course. Now this is called a non-rebreather mask. Especially, this one doesn't have it. There's like this little flutter valve off to the side, which holds all the oxygen that's coming out of the tank in this area and takes it from the reservoir bag, right? Otherwise, if you have it off, it mixes with oxygen in the room. So this is no longer a true non-rebreather mask, is it? When you inhale, or a patient inhales, because they have to be breathing on their own for this to use. If they're not breathing, right, what are we supposed to use? Right? Exactly. Because now we're doing the active breathing through our hands, right? So the patient must have good chest rise fall to use this device. And when they breathe, this valve that's in here opens and delivers the oxygen from the reservoir. So that's a non-rebreather, more commonly used with patients in respiratory distress. You gotta know the difference between distress, I'm having difficulty breathing, as opposed to failure. Someone that's in respiratory failure means they're unable to breathe anymore, which again, right?
So would you use one of those if they had like a oxygen saturation of like 90%?
90%? Yeah. Yeah. Depending on how their work of breathing is. Like if they're really distressed, difficulty breathing, I'd probably go to a BVM at 90%. But if they're in moderate to mild distress, maybe I opt for that non-rebreather in the beginning. Or a nasal cannula, maybe at 4 liters per minute. sometimes it's going to be your judgment call. If you get that gut feeling like, holy crap, respiratory distress is happening, they seem to be progressing rapidly to failure, I'll be a little more vigilant with oxygen, the higher levels of oxygen. So that's a non-rebreathing mask. The last one is Venturi. I'm very surprised she found it, because they're not on ambulances anymore. Like I said, nasal cannula on the ambulance, non-rebreather on the ambulance in pediatric to infant sizes to adults, because they're the most common uses. The Venturi mask I used when I first started working on an ambulance like 20 years ago, and they lasted for about 5 years. You're more commonly going to see this now in like an ICU. And the reason for it, because all these different colored adjuncts here that hook to the end of this deliver very specific concentrations of oxygen. Right, so if I put this orange one on at 12 liters per minute, and it says it at the bottom, it can deliver 50% oxygen. If I use this green one at 8 liters per minute, it carries 35%. And then the yellow at 4 liters, 28%. And then 8 liters for 40% with this one. So they're all a little different. People are prescribed this amount of oxygen. So typically they've already seen a specialist. They're on specialized therapy that take very specific concentrations of oxygen. And that's why it's rarely seen anymore. Because we like to have concentrations of oxygen up to like 99% delivered to our patient, right? Cannula. What I'm gonna do is gonna look for a brand new nasal cannula, and maybe a couple of you can try it on each other.
So do you want just like
Oh, sorry.
Yep.
2 on the thing here?
Yeah, 2 liters. So yeah, you can leave the regulator off and just do the setup first. For safety, sometimes if you put it on 2 liters initially, that's fine as well. Because imagine if it was on 15 and you didn't have it hooked up to your patient, but you understood that there's a lot of oxygen coming through that, right?
Yeah.
Some people get that little surprise. Yeah, 15 liters per minute or higher. And then the close up of the nose, of course.
Sorry, my hair's in the way.
No worries.
Easy as that. And then just make sure it's at 2 liters
It's at 2.
and your tank is on, right? There you go. Okay, thumbs up. Good job. Next up. That took a minute. Perfect.
That smells nice.
Yeah.
The lemon
Oh,
scented
yeah.
one.
Yep.
I like that stuff.
The aloe vera one's not too bad.
Yeah.
I take lemon over that stuff any day.
Yeah.
It's probably cheap. I'm gonna say. Siren was that was good timing on that song.
That was perfect. So what do,
So put it to 2,
okay.
put it to 4, then 6. Right? Uncomfortable, comfortable at 6.
That's so comfortable at 6.
Okay,
yeah.
6, okay, 8.
So
Okay, all right, go 10.
just feel
Just
like
don't
it's
go
from-
higher than 12.
Okay.
That sounds like it sucks.
Do you feel at the back of your throat yet?
No.
Okay, a little higher.
That's 15.
That's
No, I
enough.
feel it back
You
there.
can you can feel it now. Okay. So imagine that over a period of time, how dry all your oral mucosa will be. All right. Thank you, everybody.